Ladies and gentlemen, please stand by. Your webinar is about to begin. Please use the volume controls on your computer or phone to adjust the sound for this presentation. Good day and welcome everybody to Canadian Obesity Network webinar series. Today's presentation, Redefining Obesity, is obesity a mental health issue. My name is Nicole and I will be hosting today's webinar. This public webinar series is an exciting opportunity for the Canadian Obesity Network to interact with Canadians to disseminate credible and evidence-based information about obesity. Through this platform, experts will weigh in on issues in obesity bias and discrimination, prevention, treatment, policy, and more. If you'd like to be a part of our public community and want to be the first to know about future webinars, please become a member at obesitynetwork.ca/public and opt in for our newsletter. An archive of this webinar will be posted and available for viewing on the obesitynetwork.ca/webinars page. Due to an extremely high volume of requests to join this presentation, we have disabled microphone and question and answer features. However, we do want to answer any questions you may have, so if you have any questions you'd like to ask the speaker, you may do so via social media or in the evaluation survey at the end of this presentation. Now I'd like to introduce Dr. Valerie Taylor. Dr. Taylor is the mental health lead for the Canadian Obesity Network, a scientist with the Women's College Research Institute, psychiatrist-in-chief at the Women's College Hospital, associate professor in the Department of Psychiatry at the University of Toronto, and a lead for the Brain Heart Project with the Centre for Addictions and Mental Health. Dr. Taylor?
Thank you for joining me for this webinar looking at redefining obesity. Is obesity a mental health issue? In terms of disclosures, it's important that I recognize that I have done work in the past for a number of pharmaceutical companies, Sanofi, Shire, Novo Nordisk, and Valiant. My work with these companies is always around consultation about the links between mental health and obesity, which is what we are going to be talking about right now. So I always like to start off with this picture because I think it really helps us get into context what we're talking about when we refer to words like the obesity epidemic. And so for people who don't recognize this, this is a scene from Disney and it's a Small World ride. And if you're not familiar with this ride, essentially you sit in boats like the red boat that we see here and you travel down the canals and you look at Disney scenes. A number of years ago, this ride had to be shut down for safety reasons related to the size of the North American child. Essentially, they were no longer fitting in the boats safely and the boats were sinking and the ride wasn't working. That ride had to be shut down and revamped for safety reasons, purely based on the changing size of all of us in North America over the course of the last 30 years. And so I think that better than statistics or graphs, this highlights what we're talking about when we say we have an obesity epidemic occurring. And if we think that we have an obesity epidemic in the general population, I think when we refer to individuals with mental health, as you can see throughout the rest of our presentation, they have so many additional specific risk factors over and above what those of us in the general population are dealing with. And so I think for them, epidemic is not even the correct term anymore because it's become such a significant issue. It really is life or death. So when we think about just the increased risk of obesity, you can see here this is looking at individuals with bipolar disorder and depression, and just the risk of these individuals having the illness of obesity. And you can see that it's quite significant for both depression and then for bipolar disorder or for manic depression. So we're talking about over 25% for depression, almost 50% for individuals who have bipolar disorder. If we look at individuals with schizophrenia, for example, you can see this graph shows that the bars in red, individuals with schizophrenia, the bars in yellow, people without that diagnosis, and you can see once the BMI starts to move into the overweight range. The red bars start to overtake the yellow bars, and that trend continues as BMI increases, indicating that this is a population that really struggles with health issues related to weight. Weight and mental illness is also bidirectional, and what we mean is that if you have a psychiatric diagnosis, you're more likely to have struggles with your weight, but if you also have weight that starts to cause you difficulties, your BMI starts to get above 30, you're more likely to have a psychiatric illness. And that certainly does not mean that obesity is a mental health disorder, but it does mean that certainly individuals who are struggling with BMIs that are becoming in the range for a diagnosis of obesity, that they're much more likely to have issues, for example, with things like chronic pain, and it's very difficult to stay positive all the time if you have problems with pain. It's also more difficult for them sometimes to engage in the activities that they would like to do. We also know that there's a lot of stigma and shame associated with excess BMI, and individuals are sometimes not as appropriate with people who who have obesity. And certainly I've had clients report really being the subject of a lot of bias and discrimination, and all of those things can impact certainly how people feel with respect to mood. Whatever the association between obesity and mental health disorders, we know that certainly from a mental health perspective that we've been able to quantify excess loss of life associated with physical health problems in this population. And essentially what it means is that individuals die 10 to 15 years before they should, secondary to physical health issues. Many of these physical health issues are as a consequence of obesity, cardiovascular disease, complications associated with diabetes, hypertension, those types of situations. And so this is really an issue that's important that we understand. If we think about the interaction between mental health and obesity, there's a number of ways in which the two conditions can overlap. And this is a picture of the Diagnostic and Statistical Manual of Mental Disorders, or the DSM. The DSM is essentially the Bible that we use to make diagnoses within mental health. Policies, which we'll talk about a little later, is just the impact of the treatment of mental illnesses on weight. And so this is just a picture of the different types of broad classifications of medications that are used to treat many psychiatric diagnoses, and the size of the bubbles represent the size or the risk of a particular side effect. And so as you can see at the first half of the slide, it says first generation antipsychotics. This refers to older antipsychotics that were initially used to treat a number of mental illnesses, and you can see the largest bubble is neurologic side effects. And so these medications had as side effects things like tremor, or something called Parkinsonism, which was essentially a rigidity of movement associated with their use. And so as a consequence, people tried to develop medications that would have less of those which are broadly classified as second generation antipsychotics, had much smaller risk of neurologic side effects, but are significantly associated with things like weight gain, diabetes, and lipid problems, and as a consequence, cardiovascular disease. And so just the treatment of mental illnesses has become a significant risk factor for weight issues and weight-related illnesses. We also know that food can really serve a number of important roles for people over and above just satiety. And we know that, for example, people often report that they eat when they're stressed, and a lot of individuals will talk about being stress eaters. Certainly there's some controversy around this association, but there does seem to be, for some people at least, a real link between just eating certain foods and a calming function. One association is that it actually, for a short period of time, increases neurotransmitters such as serotonin. And that serotonin is actually associated with illness. Now, other people refute this explanation, and it may be simply related to linking food to calmer situations. And so, for example, when you were a child and something bad happened, you would be giving food as a way to help you feel better. And so this has developed then into a coping strategy that people associate food with feeling calmer. Whatever the consequence, this is often a pattern that we need to address if people are going to be successful in trying to adopt a more healthy eating pattern. The same association occurs with cortisol and depression. And so cortisol is a stress hormone, and it's normally associated with stressful situations and can be very helpful in those situations. If you go outside and you see a bear running up your driveway, your cortisol is going to increase. Cortisol, however, is also increased by adipose tissue, and cortisol is the hormone that is associated with depression. And so you can see that if you have depression and you have increased cortisol, we can try to give you medications to make someone feel better, but as a consequence, that change in cortisol may be not as effective if those medications then cause significant weight gain, and that adipose tissue or fat tissue then subsequently starts to increase the cortisol level again. And so this association can be quite complicated and may be part of what's going on when we talk about the obesity and mental health connection. If we think about other psychiatric illnesses, this is a graph looking at the link between attention deficit disorder and binge eating, and you can see that for individuals who have higher scores on ADHD rating scales, their chances of having issues with their weight and binge eating disorder increase. And again, this association shouldn't be that surprising. A lot of the behaviors associated with trying to eat healthy involve making mindful choices, not being impulsive in terms of food choices. When we try to help individuals adhere to changing their diet, we get them to write down what they're eating, we get them to try to follow a meal plan, and those are things that are difficult to do if you have attention deficit disorder. And so certainly that's one of the things to think about if somebody is struggling with their weight and really unable to stop with the impulsive eating, is that they have attention deficit disorder or binge eating disorder. Certainly another issue is the association between ADHD and sleep and weight difficulties. Certainly there's a lot of evidence to show that individuals with ADHD have problems with their sleeping pattern, have a short sleep duration, do things like tend to skip breakfast, and can have weight fluctuations between 10 to 20 kilograms in either direction, which can be very frustrating for them. Sleep difficulties just on their own have also been associated with weight challenges. And again, this is relevant to mental health issues because problems with sleep are a symptom that are pretty common across a number of psychiatric diagnoses. And so we know that when individuals are preparing to go to sleep, there's a series of events that happen within your body. So essentially your body starts to ramp down for sleep. And so hormones such as leptin, which are considered to be satiety hormones and tell the body that you're not hungry anymore, and decrease hunger, are secreted normally, and that when we wake up in the morning, hormones such as ghrelin are secreted by the stomach to indicate that, you know what, we haven't eaten in the last 7 hours, time to go find some food. If you have significant sleep derangements, however, this normal circadian rhythm gets distorted, and so people can be awake at 2 in the morning and your body starts to get a little bit confused about what time it is, and so often you suddenly start to feel hungry. At the same time, there's not a lot to do when you're awake in the middle of the night, and this boredom eating or emotional eating to self-soothe also occurs. We see the same patterns in individuals who do shift work at times, for example, even separate from a mental health diagnosis, because again, just fragmented sleep makes it difficult for them to get their bodies on a consistent eating pattern, and we have to do a lot of work in order to really help them achieve that type of consistent eating. There's a lot of interesting and controversial information about the concept of food being an addiction, and that just like other drugs of abuse, that food is something that individuals can be addicted to as well. This is certainly a complicated topic, but essentially we know that what this slide is showing us is that drug consumption and food consumption essentially activate a number of the same pathways in the brain: your dopaminergic system, your cannabinoid system, serotonin, and opioids. And so again, you can see that the whole concept of wanting and craving certainly can be similar for the consumption, especially of very palatable, high sugar, high fat foods that are really designed to not necessarily be so nutritional, but to really stimulate craving behaviors. And that doesn't mean that people who struggle with their weight have a food addiction, but I think this type of information is more useful in thinking that simply saying, I'm not going to eat food X or food Y anymore and it's going to be okay, is simplistic, and that people shouldn't frustrate themselves by trying and failing to do these types of things. This is a complicated association. We know that any substance, whether it's a drug or a highly palatable food, are associated with things like an increase in dopamine, and then dopamine being a neurotransmitter associated with reward-seeking behavior, and that we get a downregulation in these receptors over time. This is what happens when people use a drug of abuse, and this is what leads to something synonymous with drug use, which is tolerance, which essentially means they have to keep using more and more of a drug in order to get the same effect. And that same pattern seems to happen for some people, certainly in association with their eating behaviors. And then when they stop eating a certain food, they really get into what we call a reward deficient state, and they do legitimately start to feel unwell. And so it's important that we recognize the complexity of this association. And for somebody who's trying to change their eating patterns and struggling, it may be that you need to do a more complicated approach, and that probably should be done hopefully with some sort of healthcare professional. Certainly, we also know that when somebody is abusing other substances, such as alcohol, for example, that these types of things can be used and impair our judgment. And so people will often report that when they're trying to really address their eating behaviors, there's a lot of calories in alcohol, and they will often binge on foods when they're more impulsive secondary to using other substances. Again, people who often have significant struggles with other substances often need to self-medicate their emotions, and that can be done with other substances or with food as well. And so certainly there are a number of parallels between struggles with inappropriate use of food and inappropriate use of other substances. The whole concept of the history of abuse, and we can mean certainly sexual abuse is unfortunately the most common, but we see this with physical abuse or emotional abuse as well, that individuals who have experienced significant problems with abuse as children or young adults are more likely to have issues with weight problems as an adult. And there are a number of reasons or explanations for this. It can be that individuals who were abused as children use food, as discussed previously, as a way to self-soothe or calm their emotions. They also want to get bigger because they associate being bigger with an ability to be able to defend themselves against their abuser or any other people that they feel want to harm them. There's also an association, unfortunately, at times where people blame themselves for the abuse and think that there's something about the way that they're acting or the way that they look that is bringing on the abuse. And while we clearly know that this is not true, people will use food as a way to change their appearance, hoping that if they can look differently, that the abuse will stop. And so again, this is important just to understand why some people struggle with their weight, and to also understand why for some individuals, when they begin to successfully lose weight, a lot of these issues get pushed to the forefront, and this needs to be addressed in order for the weight loss to be successful and to help ensure that patients themselves are able to be content and secure and feel safe moving forward. Binge eating disorder is also a psychiatric. There is another psychiatric illness that, not unsurprisingly, has been linked to weight difficulties, given that at the core of this illness is overconsumption of food. And so binge eating disorder was recognized only in the last few years as a distinct eating disorder, and before that it had been considered to be a research category, in that people were trying to understand if it was an illness that was distinct from impulsive eating with attention deficit disorder, for example, or some other type of pathology. And it was deemed that yes, in fact, binge eating disorder is an illness that can occur on its own distinctly, and that it's associated with treatments that, when applied, can help address some of these symptoms. And so as a consequence, it is now considered to be an eating disorder. If you think about the prevalence of binge eating disorder, it's actually quite significant. So the world lifetime prevalence is almost 2%, 12-month prevalence of 0.8%, and that translates in Canada to over 150,000 adults at any given time. In terms of weight issues, you can see here that clearly most individuals with binge eating disorder, in terms of their weight category, would have the illness of obesity. A number of them also experience the illness of being overweight, and you can also see that 25% are a healthy weight, but certainly the normal trajectory of this illness is that people move up between categories. And so significant number of individuals who have a BMI of below 25, if the illness continues in 10 years, will have most likely gone on to experience overweight or obesity. So in terms of just binge eating disorder and how it's different from anorexia and bulimia, so clearly with binge eating disorder, there's no intense fear of weight gain that you see associated with anorexia, though clearly people are unhappy if their weight starts to become a problem for them either because of psychological reasons or physical reasons. And that's often what brings them into treatment. There's no inappropriate use of any purging type mechanism in order to try to lose weight after they eat a significant amount of food, and that's the essential difference between binge eating disorder and bulimia. It is an illness that we really have to be careful with diagnosing, for example, and we need to make sure that people recognize that certainly not everyone who has obesity has binge eating disorder. Not everyone who has binge eating disorder has obesity. And I think that spending some time to really tease these apart is going to be important in order to ensure that people get appropriate treatments. We've just talked about a number of the associations between mental illness and obesity. I'm going to now play a video that was done by a master's student of mine at the University of Toronto. Her name is Wu Cheng in the Biomedical Communications program. And so this video, I think, is a really nice summary of some of the things that we've talked about before we start to go into some strategies to help with behavioral change.
Obesity and depression are two health epidemics affecting millions of Canadians each year. We're increasingly aware that the two illnesses are interconnected. But how? Does depression cause excessive weight gain? Or could the effects of being overweight lead to depression? Which comes first? The relationship between obesity and depression is bidirectional and far from simple. There are four main mediators that affect how mental and physical health interact: behavioral factors, including diet and exercise; psychological factors, such as self-esteem, body image, or a history of trauma; social factors, such as stigma, financial stress, and support networks; and finally, biological factors, such as genetics, inflammation, and medication side effects. These mediators between obesity and depression are what complicate the treatment process. Let's focus first on how depression influences obesity. Depression may be caused by insufficient chemical signaling in certain parts of the brain. Neurons release neurotransmitters called monoamines that bind to specialized receptors on the neuron beside it. When there is not enough neurotransmitter within the brain, the neuron is unable to become activated, and the chemical message becomes lost in translation. We call this the monoamine hypothesis of depression. Behaviorally, a person with depression may adopt an unhealthy lifestyle or use food as a coping mechanism. Psychologically, they may become unmotivated about engaging in healthy behaviors. Socially, individuals often withdraw and isolate themselves from their support networks. The lack of understanding surrounding mental illness can make it difficult for friends and family to know how to help. Stigma can also prevent the individual from seeking the help they need. Biologically, many of the medications used to treat depression have side effects that may contribute to weight gain. Most of the currently available antidepressants work by increasing the neurotransmitter serotonin, which is involved in mood, appetite, and sleep. Others may increase neuroepinephrine or dopamine. 1/4 of patients taking antidepressants report weight gain as a side effect. Weight gain is a major reason why patients stop taking their medication. Another biological effect of depression is the buildup of cortisol, a hormone that regulates stress. Cortisol is produced by the hypothalamic, pituitary, and adrenal axis, or HPA axis. Usually, cortisol sends a signal back to the HPA axis to limit its own production, creating a negative feedback loop. However, depression can reduce the effectiveness of this loop, causing uncontrollable cortisol production. too much cortisol can lead to obesity. Now let's talk about how obesity influences depression. Weight management can be stressful and bring with it feelings of guilt and shame. Behaviorally, a person may engage in unhealthy dieting and subsequent binge eating. Binge eating disorder affects 30% of people with obesity and is linked to depression. Psychologically, obesity is associated with body image issues and low self-esteem. Socially, obesity is the target of widespread stigma. Biologically, obesity is linked to mobility restrictions and increased rates of chronic disease that can directly impact mental health. Furthermore, obesity can decrease the effectiveness of antidepressants. The proposed mechanism for this is inflammatory dysregulation. Fat secretes proteins called cytokines, which play an important role in promoting inflammation. These cytokines neuron death. The connection between depression and obesity is complex and multifactorial, and there is much that we still do not fully understand. These two conditions are usually treated as separate problems, when in reality they are closely intertwined. Healthcare providers should be watchful for weight gain in patients with depression and mindful of the mental health of patients with obesity. Instead of simply dieting for obesity or taking medication for depression, patients should be supported to engage in healthy lifestyle changes, which would benefit their well-being as a whole.
Understand a number of ways in which obesity and mental health are linked. Talked about some of the ways in which mental health illnesses and obesity are linked. Let's look at some of the things that we can do in order to try to help us address some of the ways in which we can ensure that we can live healthy when you have a mental health diagnosis. So one of the things that's important to recognize with respect to behavioral change is that our brains are lazy. And this is important to remember because that means behavioral change is going to be hard work. And you're really going to have to work at it 1, 2, 3, or 20 times in order to really make a behavioral change stick. It's also important to recognize that stress makes us more susceptible to fall into bad habits. And oftentimes people will report really feeling like they were doing well with making a behavioral change, and suddenly, as soon as a stressful event comes back, they're much more likely to fall back into maladaptive coping mechanisms. And willpower can also be a limited resource. And so just like you wouldn't suddenly start running and try to do a marathon when you hadn't had a history of real strenuous exercise and hadn't built up that muscle strength or cardiovascular reserve, so too the same thing occurs with respect to willpower. You can't make a number of changes at once. We really do have a finite amount of willpower, and this is something that we need to slowly build over time by setting reasonable goals and expectations for ourselves. If we think about building willpower muscles, some of the strategies that can help us do that, again, just use a running analogy and sort of building up from 0 to 2 kilometers and 3 kilometers onward, you do the same thing with building up willpower strength. So pick gateway habits, and so habits that are a little easier to change and that will help you make bigger changes down the line. Write these habits down, whether it be meditation or exercise, and then slowly start to do that type of work to build habits that will allow us to develop our resistance muscles and self-control. Since your willpower is limited, it's really important to establish a habit so willpower is not being used. And so what that means is really make something automatic. And so you know that you park in a different spot, and so you have to walk to work, and that suddenly increases the amount of exercise you're getting. if you park your car at a certain place, you have no choice but to walk, or else you can't go to work. And so that doesn't involve as much willpower if you get into the habit of parking in a different spot, for example. Certainly there are programs to help you with behavioral change, and this is an example of a book that I produced with some colleagues a number of years ago that focuses on using tools related to cognitive behavioral therapy, but viewed at addressing weight issues. And so one of the things that is really common in people that are trying to change a behavior is that they have something we call cognitive distortions, and that they think about things in a way that's perhaps not so helpful and can at times be quite negative. Some examples of this would be all or none thinking. And for individuals who are struggling with their weight, for example, we think that individuals with obesity are often on one end of the food continuum or another. I'm on a diet, or I'm binging, for example. Overgeneralizing, so applying rules from one situation to another. For example, thinking that I failed at sticking to the weight management goals I had for myself, and so that means that I'm a failure in general. And clearly, these types of thinking can really impact a person's mood. Selective abstraction, where you focus only on failures and not on any of your successes, or self-referencing behaviors, where individuals think they're the center of everyone's attention. For example, when someone's eating in public, thinking everyone's looking at me and I shouldn't be eating this, and really having those types of thoughts impact mood and self-esteem, and of course make it more difficult to engage in positive behavioral change. Part of cognitive behavioral therapy also includes self-monitoring plans, in which people are asked to write down what they eat, but not just what they eat, but where they eat it in the circumstances, to really try to understand links between certain eating patterns and what you're thinking and feeling, and then to really engage in realistic goal setting and structured, gentle, achievable behavioral change. There's certainly components of motivational interviewing that are also important for behavioral change. And motivational interviewing is essentially a type of therapy that's designed to help people address the continuous fluctuation between opposing behaviors and thoughts. I should do this, but I also should do that. And one of the issues with motivational interviewing is the whole concept of really moving people along from thinking about changing a behavior to actually starting that behavioral change, and moving from contemplation to preparation into action. But the key is to also remember that these circles go both ways, and that everyone, regardless of the type of behavior they're going to change, they're going to have periods in which they're going to relapse, in which they're going to not be as successful as they want, and to not let a whole behavioral change strategy get derailed because of that. So in terms of the key elements of behavioral modification, clearly the self-monitoring piece, whether it's tracking via a phone app or writing things down, or whatever seems to work for people, is a real important aspect. And I certainly like to do self-monitoring, not just a particular behavior like what I've eaten or what I've done, but again, the context, in order to identify patterns. Behavioral shaping, which includes goal setting and just gradually working up to something, and then stimulus control, so looking at a variety of barriers and temptations that may be blocking you from achieving a particular goal. And this is something that once you start to do self-monitoring may be easier to identify. We also want to enforce good behaviors like getting reasonable amount of sleep, for example, which can be helpful to achieving your goal, and to really work on strategies for stress management. And so don't fall back into old habits of dealing with stress that we're trying to change. If you're thinking about changing a habit, it's really important to know triggers. Don't think you can outsmart old habits. It's better to try to avoid them. So, that goes along with make it easy to be good and hard to be bad. If you don't have a dozen donuts in your house at midnight, you can't eat a dozen donuts in your house at midnight when you get stressed. And so really look at trying to change your environment to make it easier for yourself to be able to achieve the goal that you're trying to achieve. It's really important to give yourself credit and to change just one habit at a time. And so don't suddenly decide that you're going to start to completely change up your diet, change up your sleeping pattern, suddenly start to exercise and do a whole other host of things. Practice mindfulness and try to slow down. So wait 10 minutes, for example, after you've eaten something to really let your brain and body process what's going on. Getting social support and making it public can also be helpful for people. Tell others about your goal. Encourage them to help you and perhaps join you in activities like consistent exercise. It can be much harder to change your mind if you've committed to doing something with another person. Remember, it takes some time to change a habit, and the beginning is the hardest. It's important to be prepared with if-then plans, and so to really think about if I have to go out for dinner with colleagues at a restaurant and I can't eat the food that I've prepared, or it's going to be difficult for me to do calorie counting or to eat a certain way, then have some contingency plans for that. And then I'm going to make sure that I'm not that hungry when I go out, that I've eaten appropriately, or whatever seems to make sense. It's really important to slowly change your outlook and thinking as you develop a new belief, and to catch some good habits. So really enforce things that make you feel better. Again, getting a proper amount of sleep can be one of them. Webinar. I hope it was helpful to help understand some of the many associations between obesity and mental illness, and I hope you were able to learn some behavioral strategies that you can now implement to help you achieve whatever goal is important to you.
Sharing this information, and thank you to all of you for taking the time to join today. For those of you that use social media, you can tweet us using #ObesityTalk, send us a message on Facebook, or click on the survey box in the window on your screen and complete the survey. You may disconnect and close your window browser. I hope you have a great day.